Welcome to the new episode of Dr. Kayhan Show. I am Senem Ulusoy and I am the presenter of this program. Also, I am the patient of Dr. Kayhan. Today we will talk about many interesting subjects. This program will be in 4 sections. In the first section, we will talk about model diseases, anorexia nervosa. In the second section, we will try to talk about healthy feedings. And in the third section, we are going to talk about obesity and hepatosteatosis. At last, we will talk new information about medicine science. Let's start, Dr. Kayhan. What is anorexia nervosa? And what is its diagnosis and treatments, please?
Anorexia nervosa and also his brother bulimia nervosa are eating disorders in young, previously healthy women who develop a paralyzing fear or becoming fat. And in anorexia nervosa, this aim is achieved primarily by radical restriction of food intake, the end result being emaciation. In bulimia, massive binge eating is followed by vomiting and excessive use of laxatives. In high-risk populations such as 16 to 18-year-old girls in private schools, the incidence rate was 7.3 per 100,000 population per year. Diagnostic criteria for anorexia nervosa: first one is refusal to maintain body weight at or above a minimally normal weight for age and height. The second one, intense fear of gaining weight or becoming fat, even though underweight. The third one, disturbance in the way in which one's body weight or shape is experienced, undue influence of body weight or shape on self-evaluation or denial of the seriousness of current body weight. The fourth and the last one in postmenstrual females, amenorrhea, the absence of at least 3 consecutive menstrual cycluses. Specified type, there is 2 types. One is restricting type. This is the most one. During the episode of anorexia nervosa, the person does not regularly engage in binge eating or purging behavior. The second one, binge eating, purging type. During the episode of anorexia nervosa, the person regularly engages in binge eating or purging behavior. The diagnostic value of a disturbed perception of body image in patients with eating disorders has been questioned because many normal women evidence the same perceptual distortion. Anorexia nervosa is a chronic disorder characterized behaviorally by self-induced weight loss, psychologically by body image and other perceptual disturbance, and biologically by physiologic alteration that result from nutritional depletion. This disorder was first reported 300 years ago by Morton. In 1874, Gould first used the term of anorexia nervosa in reporting a nervous morbid disease associated with loss of appetite and severe wastings. And let's talk about its treatment. This is a long and hard, severe treatment. First one is general medical care. First of all, they need medical and nutritional care of the patient and provides psychological support. The second one is nutritional care. All anorectic patients require some dietary management, although nutritional supplementation is not needed unless the patient is at risk of medical complications with severe malnutrition, weight less than 65% of ideal. Hospitalization is usually required, and after hospitalization, tube feeding into the duodenum may be necessary. The third one is pharmacotherapy, and we know that this kind of pharmacotherapy isn't airtime useless, because these illnesses affects both gastrointestinal system and psychology also. Chlorpromazine, amitriptyline, such as lithium carbonate and cyproheptadine, have been reported effective in small short-term inpatient treatment trials. The last one is psychotherapy. This is an important therapy in these illnesses. It used to help the patient modify to aberrant eating behavior and to improve psychosocial function. Family therapy offers the best potential for long-term benefit.
Okay, thank you. Now we will talk about healthy feeding section. Dr. Kayhan, what is polyphenols?
The polyphenol is an important matter which protects our healthy body from free radicals.
Okay, what is the good effects of polyphenols?
This is a fat burner, muscle repairment, protect our body from obesity, increased metabolic activity, protect our body from cancer, decreasing blood pressure, antioxidant, regulate fasting sugar level. This is important in diabetes also, and also decreasing diabetes mellitus risks, decreasing osteoporosis risks and inflammation, decreasing stress, treating eczema and psoriasis, anti-aging, increasing healthiness of hairs. It's good for digestion, decreasing or protecting from demands, decreasing cholesterol, and also constipation.
Okay, where can polyphenols be? In which kind of foods we can find polyphenol?
All green vegetables, coffee, green tea, cacao, strawberry, blueberries, raspberry, orange, grapes, berry, cherry, apple, soya bean, almond, and hazelnut.
What do you think about ginger?
Ginger is an too important food. It includes chrome, zinc, and magnesium, and it by the effect of chrome and zinc, it increases blood flow by this way. It inhibits more sweating, fever, and fever shaking. It balances body fever. It inhibits vomiting and nausea. Also, it stimulates gastric enzymes and pancreatic enzymes. This is an old age feeding. In the middle age, some doctors, middle-aged doctors, used ginger for fever. Also, anti-inflammatory, immune modulator. It protects our arterial vessels from cholesterol.
What can you tell about lycopenes?
It's the power of the red. It's an antioxidant which protects us from free radicals. Lycopene occurs red color both in vegetables and fruits. It's found in tomato, apricot, grapefruit too much. It protects our cardiac health. It decreases lower density cholesterol, and it decreases our osteoporosis risks too.
Okay, now let's talk about turnip.
We called it in Turkish shalgam, and we drink too much in our city of Adana, we know it. This is an antioxidant. It includes a lot of glucosinolate. Glucosinolate protects our liver from toxins. Anti-inflammatory. It includes a lot of B vitamins, also C, A, E, K vitamins too. Immune modulator. It renews cells of body. It protects all cells from DNA damaging. We know that some cola drinking filled with gases they damage our cells DNA, and it protects us such kind of damaging, and it inhibits also constipation.
Okay, now in third section we are going to talk about obesity and its bad progression, non-alcoholic steatohepatitis and hepatosteatosis.
Firstly, we will try to talk about gastrointestinal complications of management of obesity. Over the past 4 decades, obesity has become a major public health problem with catastrophic impact on morbidity, mortality, and healthcare costs. Obesity may be associated with esophageal diseases, including gastroesophageal reflux diseases, erosive esophagitis, Barrett esophagus, esophageal carcinoma, and adenocarcinoma, gastric disorders encompassing abnormal motility, gastritis, and cancer, and pancreatic disease with pancreatitis and carcinoma, and colonic disorders including diverticulitis, polyps, and cancers. Obesity-associated hepatobiliary diseases included non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, hepatocellular carcinoma, gallstones, and gallbladder cancer. Also, hepatic complications, non-alcoholic fatty liver disease, which is often related to obesity and may progress to non-alcoholic steatohepatitis and cirrhosis, has become the most common chronic liver disease, and non-alcoholic steatohepatitis has displaced hepatitis C as the most common indication for liver transplantation in adults. Obesity is also associated with increased risk of hepatocellular carcinoma with or without the presence of non-alcoholic fatty liver diseases. The link between obesity and non-alcoholic fatty liver disease is often mediated by insulin resistance with mobilization of free fatty acids from adipose tissue as a major source of substrate for hepatic triglyceride synthesis. In non-alcoholic steatohepatitis, additional histologic features include hepatocyte ballooning, inflammation, and fibrosis that may progress to cirrhosis in approximately 20% of patients. Accumulation of lipotoxic lipids in the hepatocyte may lead to oxidant stress and inflammasome activation with resultant apoptosis and cytokine release, followed by stellate cell activation and collagen production and fibrosis. This may be complex, but this is the pathology of these diseases. Clearly, many other factors such as genes, environment, diet, and metabolic influence, also intestinal microbiome, are all responsible from non-alcoholic steatohepatitis. Insulin resistance in obesity and non-alcoholic steatohepatitis appears to be mediated by immune cells and adipose tissue. By the way, insulin resistance is the main suspect for these diseases. An elevated insulin resistance index and hypertension and diabetes mellitus and elevated serum ALT, this is the liver enzyme, were independent predictors of non-alcoholic steatohepatitis. Although hepatocellular carcinoma is associated with obesity, it may result from cirrhosis, from other causes, and attribution of advanced liver disease with cirrhosis to non-alcoholic steatohepatitis is not always clear. The prevalence of obesity and diabetes was significantly higher in patients with cryptogenic cirrhosis. Cryptogenic cirrhosis was associated with higher serum glucose, cholesterol, and triglyceride levels, increased insulin resistance, and lower transaminase levels. Diet and lifestyle changes, result in improvements in non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. Though weight reduction, here it is 10%, weight reduction is the key for the protection from non-alcoholic fatty liver disease, non-alcoholic steatohepatitis, and cryptogenic cirrhosis. Unfortunately, for many patients, effective dietary and lifestyle changes are not sustainable, necessitating other approaches. Therapy with vitamin A and the insulin sensitizer pioglitazone has demonstrated modest histologic improvement in non-alcoholic steatohepatitis. Treatment of obesity, firstly, the bariatric surgery. First one is Rogue's NY bypass. The second one is laparoscopic sleeve gastrectomy. They are both effective approach in select patients to achieving sustained weight loss and improvements in metabolic parameters in patients. 1 year after intestinal bypass surgery, endobariatrics. The second one is endobariatrics. Surgical morbidity and mortality as well as associated medical costs have spurred interest in non-surgical endoscopic bariatric techniques. These are Garan-Edwards gastric bubble, gastric aspiration therapy, various gastric balloons, sleeve devices for duodenojejunal and gastrojejunal bypass, transpyloric shuttles, endoscopic sleeve gastroplasty, primary obesity surgery endoluminal platform to place gastric fundic anchor plications, jejunal-ileal diversion, duodenomucosal resurfacing. These all therapies not likely to be definitive, but rather will likely serve as bridges to other more durable treatments, such as bariatric surgery or effective lifestyle changes.
Okay, and the last section of our program. Professor, please tell us news about medicine.
There's a lot of good news, and they are also correlated with our subjects today. First one is, this is published in United States America, Veterans Health Administration cohort study. They studied non-alcoholic fatty liver disease was associated with a 7-fold increased risk of hepatocellular carcinoma. This is too important. You have obese and you don't have any health problem, but if you are too much weight, fat is stored in your liver, and it only alone increased your cancer risk in your liver. And the second one is, there have been few studies of abdominal imaging screening of individuals at high risk of pancreatic cancer. They search some kind of patients. They have family history or genetic variants. We performed a meta-analysis of prospective cohort studies to determine the diagnostic yield and outcomes of abdominal imaging screening. They use abdominal imaging screening with magnetic resonance or endosonography for asymptomatic individuals at high risk. Based on meta-analysis, 135 patients at high risk for pancreatic cancer must be screened to identify only one patient with a high risk of pancreatic lesion. And according to this, this kind of study has a lot of too much costs, so nobody planning to make endosonography or magnetic resonance for this kind of patients for every year. The third one is misoprostol. Misoprostol is an old drug we used to protect our gastric stomach from some non-steroidal anti-inflammatory drugs or aspirin. Misoprostol heals small bowel ulcers in aspirin users with small bowel bleeding. We know that if you used aspirin or such as kind drugs for your cardiac care, in the future you have some bleedings in your small bowels. Misoprostol was associated with a statistically significant decrease in visible small bowel lesions. The fourth one, there is no association between screening for hepatocellular carcinoma and reduced cancer-related mortality in patients with cirrhosis. And the fifth one is interesting. This is a parasite. Anisakiasis is an infection illness, and this is too invaded in the east part of the Turkey and also near to the some countries near to the Black Sea. It is acquired by ingestion of the larva by Anisakis, a genus of parasitic nematode. In the Anisakis life cycle, larvae burrow into the wall of digestive tract of fish, infect marine mammals that eat the infected fish, and then become adult forms that release eggs into the seawater via host fetches. Humans who eat raw or undercooked fish. This is a tradition in near to the Black Sea and some Japanese countries or Chinese countries. You know, some foods you can't cook fish, such as salmon, sushi, become an incidental host in nematodes' life cycle. And the sixth one is in a retrospective analysis of medical claims data from adults treated with direct oral anticoagulants and hospitalized for gastrointestinal bleeding, we found that older patients who require blood and intensive care were less likely to restart treatment with direct oral anticoagulants after gastrointestinal bleeding. Resuming direct oral anticoagulant therapy was not associated with thromboembolism within 90 days or recurrent gastrointestinal bleeding. And the seventh one, in retrospective studies of veteran population, and this study is done in United States and Japanese, we associated inflammatory bowel disease and treatment with thioprins alone or in combination with TNF antagonists with increased risk of herpes zoster. With the approval of a new and potentially safer vaccine for herpes zoster, the effects of immunization of patients with inflammatory bowel disease should be investigated. And the last one, flexible gastrointestinal endoscopy offers an ever expanding many of minimally invasive alternatives to surgical interventions, most recently through procedures developed to address the obesity epidemic. Endobariatrics is a new field within gastroenterology aimed at addressing the obesity epidemic. Currently available procedures in Turkey include intragastric balloons, gastric aspiration therapy, and endoscopic sleeve gastroplasty. The reversibility and repeatability of endobariatric procedures make them an attractive option to fill the gap in obesity therapy between medications and bariatric surgery. Patients undergoing endobariatric procedures require ongoing follow-up evaluation to maintain a healthy lifestyle and long-term weight loss.
Thank you, Professor. Is there anything you want to add this episode?
Sure. The last one is a decision. This is the physiology or the logic of it. Today, first we talk about unhealthy slimming, anorexia nervosa, and then unhealthy obesity, you know. And we learned that it easily affects our internal organs. However, if we can't occur correct correlation between our mouth and brain, we will lose our health. You know, there's a old word in Turkish. If you are healthy, you must eat more. But now, today, we know that if you want to be healthy, you must eat healthy foods, not more or not less. This is the way of it.
Okay. Professor, thank you very much for your great presentation. We will give you this kind of special health information every month. See you next episode. Bye bye.